Thank you for that great introduction. So, as a radiation oncologist, our greatest fear is putting everybody to sleep, especially with it being mid-morning. I'm kind of the last person to do the first order of business today, which is primarily focused on breast cancer. So I promise no DVH curves, and I have lots of good pictures. But essentially, when I see patients and I'm talking to them about radiation therapy, especially if they have a left-sided breast cancer, they just want me to cut to the matter of it, because all they want to know about is what is this going to do to my heart. And I think it's very important for everyone to kind of understand that we do take the heart into consideration, and there are actually quite a number of techniques that we can do to minimize the dose to the heart. So I'm talking about getting to the heart of it today. So I have no disclosures. So my objectives today are kind of twofold. Number one, I want to talk about just briefly some historical context for the concerns related to heart toxicity in cancer survivors who've had prior radiation therapy. And really, most of my talk is actually going to be discussing what are some of the more modern radiation therapy techniques that we can do to minimize the dose to the heart. So just quick facts about breast cancer. I'm sure some of you have seen these slides many times before, but it bears to say that 1 in 8 women will be diagnosed with breast cancer in their lifetime, which means that most people in this room and most people we know will be affected in breast cancer some way, either diagnosed or they'll know someone, either family member, loved one, friend, church member who will be diagnosed with breast cancer. That comes out to be about 250,000 women expected to be diagnosed in the United States this year, and about 4,000 of them in the state of Alabama. There are about 40,000 deaths per year in the U.S. and about 700 per year in Alabama. So this is just a quick slide to say that the incidence and mortality from breast cancer has remained relatively stable over since 2010. This slide really is here to just give more of a wider historical picture about breast cancer survival. This actually goes back to 1975. I don't know how well you can see that, but essentially this just shows us that there's has been a decrease in breast cancer deaths since 1975, you know, notwithstanding the fact that the death rate amongst African American women is still higher compared to other groups, but it is falling compared to 1975. So now that long-term survivorship is the norm and not an exception, we're really paying more attention to long-term toxicity, and we're starting to recognize that more and more in patients, because oftentimes, even though they may be alive, simply being alive for most patients isn't good enough. They want to have a good quality of life. They want to be able to do most of the things that they want to do. And now we need to just think more and consider more at the outside of treatment how this might affect them moving down the line. So this is actually data from the British Columbia trial that randomized women to no radiation versus radiation after a mastectomy. And what I want to focus on today is some of the long-term toxicities that they reported for these patients 20 years out from treatment. The most common thing, which Spencer kind of touched on before, was lymphedema, or swelling in their arm after treatment. And in the ladies that had radiation therapy, they had about 9–10% risk of developing long-term lymphedema compared to women who received radiation alone. The other issue that they touched on was pneumonitis, which is something that is quite rare. It happens in less than 1% of patients, but when you have a patient who develops radiation pneumonitis, you never forget it, because in some of these women, they can get quite ill and end up not only in the hospital, but in the ICU. I wanted to kind of point out their non-breast cancer related deaths, that in this cohort group of women, they found about 2% of the ladies who died not of their cancer but from cardiac issues in the radiation therapy arm versus just 1 in the group that was randomized to chemotherapy. So I don't know how many of you remember this paper from 2013. It made it to the New England Journal. It was like the hot topic for several weeks. It basically looked at the risk of developing ischemic heart disease in women after radiation therapy. And so since that time, there has been thorough debates about how they came up with this estimation, which was essentially for every gray of radiation therapy that it increases the risk of a woman developing ischemic heart disease by 7%. And so that is a big deal. Nonetheless, I will say as a radiation oncologist that there was quite a bit of pushback on this paper, New England Journal notwithstanding, because they looked at data from women who really weren't treated in the modern era, nor did they have individual dosimetric data to talk about what the true heart dose was for each patient. They kind of developed a model for it. But regardless of whether or not we do agree on the methodology, it brings home the important point, especially to patients, because that wasn't as big of a question that I received from patients prior to this big article. Is now it brings that to the forefront of the mind of patients. What's happening with my heart? So let's kind of shift gears and really talk about, well, what are the effects on the heart long-term from radiation therapy? And it generally falls into 3 broad categories. There is effects on the pericardium, which is the lining that surrounds the heart, which leads to pericarditis and pericardial fibrosis. And then there are effects on the actual heart muscle itself, which leads to myocardial fibrosis. And then there is effects that radiation therapy can have on the blood supply to the heart, which is coronary artery disease. So I am not a pathologist by any means, but I think this picture is very telling. So here is your normal pericardium. So here's your pericardium here. I think this is a 150x image, so it's multiplied 150 times. But normally your pericardium is very thin, and then it's surrounded by a layer of fat. This is a patient who is about 18 months after radiation therapy, and here's their pericardium, but their fat has been completely replaced by this very dense fibrous material. So you would imagine how that might affect the ability for the heart to move. And this actually turned out to be a fatal case of pericarditis in a patient. This is a picture of myocardial fibrosis. And really what we want to know is these little areas that are blue basically looks at collagen. And in this patient who was 2 years out from radiation therapy, this was actually in a young person who received mantle radiation therapy, which is a large radiation field that includes a big portion of the chest and a portion of the heart. This is from the 80s, I might put a disclaimer. But we don't see this as much anymore, but this is still a concern that now instead of you having very faint strands of collagen tissue in the muscle of the heart, you now have these very wide, very prominent bands, and this patient actually died of radiation-related cardiomyopathy. And actually most of the concern, or the original concern of heart toxicity from radiation therapy actually came from Hodgkin's survivors who were treated back then with radiation alone. So these patients received large radiation fields to much higher doses than we do today, because most of these patients are usually going to get chemotherapy and may not get radiation therapy alone, but these were heartbreaking and very real outcomes from radiation therapy. So their disease was cured and yet died of toxicity related to the treatment itself. So this is actually a section through the left anterior descending artery of someone who was 30 and 7 years out from radiation therapy. Also received mantle field radiation. You have to find very old papers to get these pictures, but nonetheless, this is someone who had coronary artery disease in the left anterior descending, who died a sudden cardiac death several years after radiation therapy. And as you can see here, here's the lumen, which should really be more like this. But this looks like classic coronary artery disease. And that's the thing with radiation-related ischemic heart disease, is that it looks exactly like the heart disease that you would get in someone who is 70 or 80 or who had risk factors. But in this particular case, this patient, when they had a sudden cardiac death and autopsy was done, this is what was found. And when they did the correlation, it turned out that it was the heart was in the radiation field. So these are real outcomes from patients that luckily does not happen as much anymore, but they're still real concerns. So here's a proposed mechanism of action for radiation-related coronary artery disease, and essentially it relates to potential macrovascular as well as microvascular injury to the blood supply to the heart, which ultimately leads to myocardial ischemia. So let's switch gears a bit and let's talk about, well, what can we do to reduce the heart in patients, the heart dose in patients with left-sided breast cancer. So they generally fall into a few categories. You change their position, you change the way that they breathe or the way that the radiation beam is on during their breathing cycle. There's another technique called IMRT, which basically allows you to kind of shape the dose around the heart and other structures. We'll talk a little bit about proton therapy, which is a new hot topic in radiation therapy, and the centers seem to be popping up everywhere. Also, a bit about more very practical things that you can do in terms of reducing the volume of breast that gets radiation therapy through partial breast irradiation therapy, and a very novel concept that maybe not everybody needs to have radiation therapy. There are some patients that are safe to observe. So let's talk a little bit about prone positioning. The classic, I want everybody to kind of look at the right side of this slide first. Classically, the way that we would position patients for radiation therapy, they lie down on their backs with their arms up over their heads. That way their arms are out of the radiation beam when we treat the breast. And so in this position though, in someone with the left-sided breast cancer, of course you are able to treat the breast tissue, but you also are very close to your heart, and also there's lung that also receives radiation therapy. Now there are modes that we can use to put a patient on their stomach. And when you lie on your stomach, of course, it pulls the breast away from the chest wall, away from the lung and also the heart. So you're able to treat the breast tissue and yet completely spare the lung and the heart itself. Now, this position works well for ladies who have especially very large breasts, but there are clearly patients who would not be able to tolerate lying on their stomach even for 15 minutes a day, especially if they have a large abdomen or if they are not very mobile. Sometimes it's an issue for some ladies if they can't get their arms up to kind of wrap around the mold. And of course, it would be a real issue if you got a breast cancer that's very close to the chest wall. Sometimes this technique is not feasible for those patients. So what else do we have? The other way that we can reduce heart dose has to do about just modifying and having patients hold their breath during treatment. So this is also kind of our classic radiation field. This is when a patient has what we call free breathing, or they're just breathing normally. In most patients, if you have them take a breath, it actually displaces the heart inferiorly and laterally. So it allows us to be able to treat the breast tissue and stay off of the heart because it gets displaced away from the radiation field. And this is another example to the right of that. And it actually, I like this slide because it actually highlights the left anterior descending coronary artery. And so you can actually see when the patient is in expiration, or if they're just free breathing, your left anterior descending artery is going to flow in and out of your radiation field. But if you have the patient take a breath and hold it with treatment, then you're able to move that area of the heart away from the radiation field while still giving proper dose to your breast. There are some patients, of course, in which, again, this isn't going to be logistically possible. If you've got a patient who has poor lung function and can't hold their breath. We also treat patients who have other issues. They just simply can't follow instructions, and you can coach them, you coach them, and you think you got it, and you don't. In those particular patients, we want to try something else, whether it's putting them on their stomach and treating them prone, or trying another technique depending on their stage of disease. Another way of modifying the radiation field with the breathing cycle is essentially something called gating, where basically the radiation beam only comes on during certain phases of the breathing cycle. We don't use this technique at MCI. We use the breath hold technique. We find that it works with most of the patients that we need, but there are places that use that technique. That when you are able to use this, you don't have to worry about the patient's ability to follow instructions. You just need them to be able to hold still and follow their normal breathing cycle, and the beam comes on and off depending on where they are in their breath cycle. So I had a really cool picture of IMRT, but for some reason I cannot get the animation to work. But the quick and dirty of IMRT is that, unlike the other techniques where we literally go in and we manually put the radiation fields on, with IMRT you set certain parameters, certain dose levels that you want organs to go to, and the computer essentially figures it out for you. It's a lot more technically involved technique, but nonetheless, this is a way in which you're able to basically carve out the dose and minimize the dose to the heart while treating your targets. So now I'd like to talk just a little bit about proton therapy, because most patients are going to come in and they're going to talk to me about this option. As patients get on the internet, they get on their support groups, and so proton therapy should actually be a part of our discussion with our patients, even if you don't have that option to offer to them. And in left-sided breast cancers, I always talk to them about proton therapy. So we use photon therapy, and most places do, but with protons, they have a technique in that they deposit their energy at certain depths, and you can kind of modulate where it deposits the energy. And so when you compare that proton, you can essentially get the radiation dose to go exactly where you want, and then there's no significant dose beyond your target, compared to your traditional radiation therapy, where in this particular case, the lymph nodes in the chest wall is my target, but due to the qualities of the photon beam, there is still some fall off of dose beyond my target, which ultimately goes to the heart and lung and other organs. So with proton therapy, you're able to get much lower doses to your heart and also to your lung. The downside of proton therapy is, number one, not all centers have it. Though it seems as if you're going to be able to have a proton center in every major city here soon. They seem to be popping up everywhere. The other issue with proton therapy is, even if it's available for some people, it's not practical for them. If you've got somebody in the Mobile area, their nearest place to be able to get proton therapy is either to go to Jacksonville, MD Anderson, and then there are a couple of privately run proton centers in Tennessee and Shreveport. And so for them, especially if you've got a woman who is a primary caregiver for her family, and if she's the primary breadwinner or the one that carries the insurance in the family, trying to ask her to go away for 6 weeks is not practical for her. And so in those particular patients, that's not an option. And lastly, the data with proton therapy is short. I think the longest set of data that we have is usually follow-up of only 10 years. So it's unsure of how if the outcomes will be better at 10 years compared to your traditional photon therapy. My personal idea is that it's probably going to turn out to be better. But until that data becomes available, you kind of have to understand that with that grain of thought. But I think that proton therapy is certainly an emerging technique, especially for left-sided breast cancers. And at the University of Florida, they're actually enrolling patients on a randomized trial, randomizing them to traditional photon radiation therapy versus proton therapy. So in my patients that are interested in it, I always offer them, if they just want to go there and have a consultation to talk about it, and I've sent a couple of patients out there. The other technique is with partial breast radiation. Partial breast radiation therapy is also a newer technique, and newer as in we've got probably 20-year data on that. But we know that in some breast cancers, there is quite a bit of success by simply treating the area around the lumpectomy cavity with a margin, as opposed to treating the entire breast. This is now an accepted form of therapy, especially if you've got a small breast cancer, node negative, in women generally 60 years or older, and it's hormone receptor positive. And we're actually in the process of trying to develop that program at MCI. And so there are multiple ways that you can do it, but it generally is related to some type of balloon device that gets inserted to give a very focused dose of radiation therapy right around the lumpectomy cavity. There are also places that have an intraoperative radiation machine where they can go in and do radiation therapy at the time of surgery. And Dr. Smith, who's not here, of course, trained and did that quite a bit when he was at Vanderbilt during his residency. So in this particular case, when you have an older patient, hormone receptor positive, negative nodes, negative margins, in those patients, you have to at least consider whether or not simply only treating a smaller area of the breast, which allows essentially you to not to have really any dose to the heart at all. And this has been shown to be just as effective as whole breast radiation. The other upside of partial breast radiation is it allows them to finish their radiation therapy in a week. This is usually 10 fractions altogether, so they get 2 treatments 5 times or 5 days a week, so it's done in a week. So this is better in terms of convenience and the overall treatment time for a lot of ladies. But of course, if you have someone who's a younger breast cancer patient or with positive nodes, of course, they wouldn't be a candidate for this. Partial breast radiation therapy can also be done with an external beam radiation machine. And I apologize, most of the pictures that I have for this were right-sided breast cancers. But nonetheless, I think the technique in the illustration is essentially the same. If this was on the left side, your heart would probably sit right here. But nonetheless, you kind of, here's your lumpectomy cavity in red. You kind of concentrate your radiation dose right around that area. You've got minimal dose that goes to the lung. And if your heart was sitting here, there would be almost no dose going to your heart. So this is not my preferred way of doing this because it gives a lot more dose to the rest of the breast. But it would still be a better option than treating the entire breast if you've got your heart sitting right up under there. So in conclusion, radiation therapy, it still remains an important component of early stage as well as advanced breast cancer. It provides a reduction in local recurrence and breast cancer mortality, but you have gains that can get offset by by late toxicity related to the heart, we didn't even delve into the lung toxicities or some of the other concerns just in the consideration of the time. So you do have to balance the benefits of the treatment with potential risk. But all of that to say that modern radiation techniques are available to reduce the risk of long-term toxicity from the heart. Also, when we're planning the radiation therapy, we contour the heart and we have dose parameters, nationally accepted dose parameters that we maintain to the heart as well as to the lung. The other thing that I don't really have time to go into discussion about, but one of the things that was reiterated before, is that oftentimes our patients come to us and they already have risk factors for heart disease. And so that is our opportunity to, for ladies who are smoking or those that have suboptimal diets and with poor, really low activity, to be able to encourage them to improve those things, because there are still risk factors for developing cardiac disease, not just their radiation therapy. And it's one of the things that I get to address through my Thrive program, which I don't have time to talk about today. But nonetheless, that is the end of my talk, and I'll take questions at this time. Yes. So that varies depending on the data that you're looking at. And this particular paper from the New England Journal, they have this huge database from the UK. So they basically, I think their earliest cardiac events were about 5 years out from radiation therapy. But there are other studies where they have looked at patients who have had radiation therapy, and they looked at nuclear medicine scans, like perfusion scans on the heart that they've done even just months after radiation therapy, and have noticed a change or diffusion effects. So I think the clinical manifestations are generally not until 5+ years after radiation therapy, but I think there are some subclinical manifestations that they've seen on things like perfusion studies that might be present as low as 6 months after treatment. Any other questions? Thank you very much. I hope no one's asleep, so I'm doing pretty good.